There we go. As far as this semester's with COVID and things like that, if we do have, y'all are expected to come to class, of course. If you have to be quarantined, that has to be approved through Miss Eric, where she has that conversation with you that you're symptomatic or some other factor made you your tracker red so that you can't come to campus. And then I will record the class so that way you can listen to it later. There are some weeks that things are just pre-recorded, like this week. Even though we're going to talk about a lot of the content, I did have it pre-recorded because it is a lot of information. Not every week we'll have pre-recorded. Y'all are welcome when you come to class to record as well, either on your phones or if you have a little recording device or whatnot. You are welcome to do that as well. Sometimes people find that beneficial, you know, when you're driving to clinical and you're listening to recorded lectures, just letting it play in the background. As far as time, though, for this class, so the time is laid out. I would recommend that y'all plan on being here till 9:30. It's not to say we are going to be here till 9:30 every single night. But the way we have this class laid out is the class time is 5:30 to 7:30. And then we have tutoring built in from 7:30 to 8:30. Depending on what is going on for that day, like some days we may be covering a little bit more content than others. We may have to go over into, 9:15 or so. So make plans for 9:30, but I can tell you we will not be here till 9:30 every single night. Some weeks it'll be a little bit heavier than others, and it helps us do a little bit extra activities to reinforce that information. Tutoring is highly encouraged because a lot of times it's where we haven't finished the content. With it being only a 2-hour class, a lot of times we're still covering content into that. Now, by mandatory, when it comes down to it, it's not mandatory for you to stay. It's, it can be, as long as you show up, you get positive for attendance. But there are a lot of things you might miss, especially in that 7:30 to 8:30. So I would recommend trying your best to make accommodations to be here, because we do cover a lot of information. It's a tough class to get in 2 hours. Any questions on that?
Not
Yeah.
on the time, but for the quizzes, I don't know if you can tell me, but is the quizzes going to be on stuff that's supposed to read before class or stuff that we've already gone over?
Both. So it will be on both. So like, for instance, next week, the stuff we cover today, like the STIs, contraceptives, stuff like that, it'll touch on that. Plus it'll touch on pregnancy, what we're covering next week. So that way it's building up to your exam. So it will have a little bit of both content up to our exam. So then when we take exam 1, it's almost like we start over. So then your first quiz after exam 1 will just be on postpartum. And then it'll be postpartum and newborn, and then like building up to each exam, if that makes sense. So expected to be primarily on whatever topic we're covering that day, but it will have some previous content as well. Good question. Let's see. Any questions? I'm trying to think. I always forget something. And I'm like, oh, I meant to tell them that. All right. So I showed y'all at pre-semester where to find everything on, getting a little warm, where to find everything on Blackboard. Do y'all have any questions on that? Like where to find the folders, the content, things like that? Make sure y'all are using any resources. Like next week, for example, I have under the pregnancy there. So the normal pregnancy stuff is pre-recorded on YouTube. We'll still talk about it in class, but it will be helpful to kind of listen to it. And then in class, we'll definitely go over more detail, the high risk. There's also a worksheet in there under week 2 content. It's not required. You don't get a grade for it, but it's just an extra resource for you to complete. I find that doing something while you're reading helps you absorb it a little bit better. I know with me, when I try to read a textbook and I sit there and read and I get to the end, I don't have a clue what I just read if I'm just sitting there reading it. Now, give me a personal book I want to read. I can remember all of it, but not a textbook. But if you're writing something or doing something, actively reading, it helps you absorb the information a little bit better. So you can use that worksheet either while you're listening to the recorded lectures or while you are reading to help reinforce the content. Something else I was going to say. I don't know. It'll come back to me. Any questions? Y'all are so excited. What's that?
With
do you mean?
So like, it was like a page, like I don't know, it didn't come out looking like a PowerPoint.
Yeah, so that's easy. You change it. So sometimes in PowerPoints, that's set up as like the notes format. So you just change it to, there's a button. Let's see yours. It's under, if you go under view, if you go under view at the top and you click on normal or outline view, it changes the view for you. So it's just, and sometimes I find, like when I print out PowerPoints, for example, on my own, that's how I print them, is where they have the space at the bottom, and that's where I'll take my notes at. So, but you can change the view on that when they come out that way. I don't know why sometimes it saves it in that view. And then I'll change it and it changes itself back. So, yeah.
I had a hard time finding it at first. I'll show you. So you have to see what on the tracking calendar. Sometimes it will say skills.
Yeah, like if it says skills module, it's under the skills module section.
Skills. So if you go to apply, I think it's it.
Yeah, I think so.
Apply. And then it will say skills module 2.0.
Yep, if you go there, and you'll find the maternal newborn module under there. So usually the first part, like on your tracking calendar, it'll tell you like the section to find it on, and then you go under and find the individual.
One that's like week 7 or something, and it says newborn as well, but that's under learning systems.
Yeah.
Okay, cool. That's awesome.
And if y'all have trouble finding it, let me know, and I can point y'all in what direction you need to go in ATI. Although y'all's looks a little different from mine, so sometimes it takes me a minute, but. All right, so let's get started talking about women's issues. I will tell you, when you're doing your readings, use your PowerPoints to kind of know what to focus on. Sometimes your book goes into topics that we aren't going, like for instance, one section of your book goes into detail about sex and stuff, and I'm like, we ain't talking about that. If you don't know that by now, we ain't talking about it. But use your PowerPoints like as you're going through your reading, and that will help you know what to focus on in your readings. Because some points of the book, they get a little wordy about things that we aren't even going to really talk about. And I'll tell you when we're going through lecture, I'll be like, all right, moving on. Because it's something to say, hey, look at this, but don't worry about it. So those will help you kind of narrow your focus of your reading. I would say doing your readings, the best way to do it so you get the most impact for your time is start with ATI, because you know ATI is concise, it's bulleted, and start with ATI for your readings. Then go to your textbook and read like the charts, the graphs, the little emergency boxes, all the little visuals that they have. And then as you have time, especially if it's a topic you're having difficulty with or that's a little more detailed, then go into reading the paragraphed portions. But ATI is good as far as giving you the bulleted, more concise information. All righty. Y'all ready? Me too. All right. Female assessment, we are not going to go into detail about, because hopefully y'all know how to do an assessment by now. And if you don't, I'm concerned. So when we are doing assessment of a woman that we're talking about in this class, 99% of it is going to be the same. Now, as we go through different topics, there may be some things we'll talk about specific to that woman's phase, like postpartum will be a big one, because then you've got a fundus to feel and all this stuff. But as far as general female assessment, most of it's going to be the same. The biggest change is going to be history, as far as their OBGYN history, looking at any kind of venereal diseases, things like that. But we're not really going into that. Same thing with genitalia. By now, hopefully you know the appearance and the functions of the internal and the external genitalia. Now, external, we definitely ain't going to focus on too much. Internal, if you don't know the functions of the female reproductive system, you're already at a loss. So I would recommend, if you don't know what the uterus does and the fallopian tubes do and the ovaries and stuff, make sure you review that information. So let's talk a little bit about menstruation. And looking at this chart, I do not want you to memorize that. Do not. It's really just there for visual benefit. There is a similar chart to this on page 30 in your textbook, your big textbook. This chart just helps to give you a visual of how our menstrual cycle runs. What happens when you say it's the first day of your menstrual cycle? What happens? What event occurs? Yeah, you start having your period. So it's your first day of your period when they say day one of your cycle. So your 30-day, 28-day, however long your cycle is. Day one is when they're looking at the day you start your period. So there's different hormones, and this will make more sense when we go into pregnancy, the effects of estrogen and progesterone. For instance, we will talk about in pregnancy that progesterone is considered the hormone of pregnancy because it maintains pregnancies. Your body sees a implanted egg as a foreign object. It's going to try and contract and get rid of it, but the progesterone calms that uterus down so it doesn't push that fertilized egg out. And as you see, like the hormones right above the shedding of the lining, you see progesterone goes up right after you ovulate, so that way it's at its highest peak, expecting a pregnancy. If a pregnancy doesn't happen, it drops right on back down. So do not memorize any of that. It's just for your visual benefit, so you can see how the hormones kind of fall in with the shedding of the lining and the ovulation and things like that. But our first day of our period is considered day one of our cycle. What is menarche? The beginning. Yes, exactly. So when teenagers go through their first period, that's considered menarche. Typically happens right before puberty, or right before puberty ends, I should say. And it's a big day for them, not in a good way. But yes, and oftentimes when they first start having their periods, they're very irregular, unpredictable, which makes it even worse for them. So when we go to the other side of the spectrum, then we have climacteric and menopause. And most people know what menopause is. That's when you cease having periods. Your hormone levels change. But climacteric is just that pre-menopause you hear people talk about. This is a period of time where you see a lot of oops babies because climacteric can last for 10 years. So to be considered in menopause, you have to have 12 uninterrupted consecutive months of no periods. So if you go 10 months without a period and then you have one, you're not in menopause yet, you're in pre-menopause. So people go, 9 or 10 months without a period. Great, I'm not fertile anymore. And then they have unprotected sex and oops, I didn't have a period, but I'm still ovulating. So you see a lot of later on oops babies happening during this time. So climacteric is that premenopause. It can last 10 years. But in order to be considered, what's important about this is in order to be considered menopause, 12 full consecutive months. So let's talk about menopause. So menopause is not just about the good part of not having any periods. There's some health risks associated with it. Probably the two biggest ones we think of is bone density and cardiac health. So I don't know if y'all talked about it in MedSurg 1, how women who are premenopausal have a much lower risk of cardiac events because of estrogen has a protective benefit. Once women go through menopause, their risk of heart attacks and stuff is the same as men because of the loss of that estrogen. So we have increased risk of cardiac events. It decreases our bone density, even in women who don't have osteoporosis, where they have softening of the bones. It increases their risk, and they should be taking like calcium and vitamin D and things like that. So when we're talking about how to manage symptoms or how to manage those risks, it used to be when hormone replacement or HRT came out, 20 years ago or so, 25 years ago, they put everybody on it. It's great. It's going to make everybody feel better. It's going to protect your bones. It's going to do all this stuff. Well, they found that it really didn't have a lot of benefit for cardiac or internal estrogen provides a cardiac benefit, but for some reason giving external estrogen doesn't provide the same benefit. And it actually increased risk of some things like breast cancer. So instead of putting everybody on it, now they base it on symptoms. So they reserve HRT really for women who are symptomatic based on severity. So when they have a lot of the vasomotor symptoms is usually the big one, where they have the hot flashes and the night sweats and they wake up in a pool of sweat. Those are the patients that they're going to put on HRT. So it's more for symptom management, for functionality and comfort, not so much for the physical preventative benefits, because it really doesn't provide enough benefit when given externally. But things we can do to help, especially with bone health, again, calcium and vitamin D. Calcium's not really that beneficial if you don't take vitamin D with it, because what does vitamin D do? Yeah, it helps pull it in, helps us absorb it so that we can actually use it. Another thing that we teach women to do, especially later on in life, whether they have osteoporosis or not, is weight-bearing exercises, something that gives resistance to their bones so that they don't disintegrate. Your bones start degrading around the age of 26. Exactly. Even in women that don't have osteoporosis, they start to just, you're up to 26, you're building more bone cells than your osteoblasts and osteoclasts. I won't take you to A and P too far, but where you're building up more than you're breaking down. And then about the late 20s, you start breaking down more than you're building up. Now, it's a slow process, but by the time you get in your 50s and 60s, you have a great diminishment in your bone density potentially. So yes, ma'am. It depends on the risk. If they have an osteoporosis history, sometimes they'll do it in their 40s. I think and it changes every few years. I want to say right now it's in your early 50s that they recommend for non-high risk. But I think with high risk, they say in your 40s, like if you have a family history of osteoporosis. But it does, all those regulations change every couple of years, like how often to get a pap smear and all this stuff. Once it used to be every year for PAPs. Now it's, I think once you go 10 years negative, you can only get it you only have to get it every 3 to 5. And what's that? Yeah, every 3 years now. I just go to the doctor and they say, okay, you're due for one. Fine. I know. Well, you have to have so many negatives, because your greatest risk of having a positive pap smear is between 20 and 30 because of HPV, which we're going to talk about HPV. But once you hit into your 30s, the risk decreases. But I agree, 30 years is a long time, especially if you don't know. Yeah. And the bad thing about cervical cancer is cervical cancer a lot of times doesn't have any notable symptoms. Usually it's kind of vague symptoms. So cervical cancer has a high risk of death, not because the cancer itself is very aggressive, but because it gets caught so late, with things like that. Ovarian cancer is that way too. A lot of times it's pretty deadly, not because the cancer itself is aggressive, but because it gets caught so late, because the symptoms are usually kind of vague. People complain they feel kind of bloated or heavy or tired, or, don't we all? All right, so we're not going to go into breast health or breast dysfunction pretty much at all. Y'all know what breast purposes are. When we get to newborns and we talk about breastfeeding, that's where we're really going to focus on breast health. But as far as preventative, general breast health, we're not really going to focus on it too much. Primary purpose, of course, is for milk production for babies. Go ahead. No, please. Yep, that's something we'll talk about in newborns. So the layman's term is called witch's milk. So especially in female babies, because of the hormonal influence from mom, for the first couple weeks, they may have a little bit of milk production from their nipples. It's totally normal. Just like newborns can have something called pseudo menstruation, where they might have a little bit of blood in their diaper when they're first born, and it's that estrogen Can you imagine your little girl's diaper? You go to change it and there's blood in it. Oh my. Right? Right. But it's totally normal. These things they don't tell you. Right. But you're right. Yep. That can totally happen. It's all that hormones from mama. So as far as most breast conditions are actually very benign. If you have breast pain, more than likely you don't have cancer. Cancer, as far as breast cancer, is typically painless. And we'll talk about the symptoms you do get. But there's a lot of reasons that cause breast pain. Being pregnant can cause it. You know, your periods can cause it. If you have an illness and you have the lymph nodes all inflamed up in there, it can transmit into your breast tissue. But most things are not concerning when you have breast pain. We're not going into all those. But things that you do look for sometimes are not things that people would think. When people think of breast cancer, they think of a lump, which absolutely that can be a sign of breast cancer. But there can be other ones as well. Skin changes are very common. I'm going to turn the light off just for a second. I'll turn it back just so you can see this. What does that look like to you? It does. An orange. So this is something, and you don't need to know the term for this. It's called peau de l'orange. It's, of course, they got to use a French word, but that is breast tissue, and you see how it kind of puckers in at all the pore points. It looks kind of like an orange peel, that rough, scaly kind of skin. That can be a sign of breast cancer. So skin changes, redness on the breast, those are actually more commonly seen than lumps on the breast. You can have nipple discharge, different things. So women should be taught, and a lot of times we're not. We're taught, you know, do your breast self-exam. If you feel a lump, tell your doctor. But oftentimes women aren't told about some of these other things, and they think it's just a rash or something. Maybe they're putting hydrocortisone on it or some kind of cream thinking it's a rash, and it's breast cancer. Peau de l'orange. Let's see if I can spell that. I used to be able to spell it. It's like peau de l'orange, something like that. Something like that. It's French. You know how those French people are. No, I'm just kidding. I don't know anybody French. Huh? They're basically the same thing.
So like when you have breastfeeding moms and they have the inverted nipple and they have to use their shield and everything else to help them, how would they know the difference between the color?
So it really is more of if it's an acute thing, like if you had an extroverted, whatever, a nipple that sticks out and then all of a sudden it's pulled in versus, because some women just have inverted nipples and that's their, you know, baseline. And that's usually what happens with breastfeeding. So it's more of, is it new or has it always been there? No, absolutely. So hopefully by now, all of you know how to do a breast exam because I'm sure y'all do it every single month, right? Kind of like me. Yeah. I know. I'm not saying nothing. I understand. So we are supposed to teach patients do breast exams every single month, you know, lying and standing up. Shower works great because of the lubrication from the water. One thing that would be good for you to know, though, is the best time to do a breast exam. Do y'all know when the best time of the month is to do it? After. So about the end of your period. So about a week after your period starts, about the end of your period is the best time. And the reason for this, typically the breasts are less tender at that point if you have tender breasts, and also the tissue is less dense and less lumpy. So if you do it at the beginning of your cycle, you might feel some lumps that are that are just dense tissue and not really anything concerning. So about a week after you start your period. And then management, again, we are not going into the detailed. This is more of just a whoosh, take care of your breast, moving on. So radiation, chemotherapy, surgery is a big one, anywhere from just a lumpectomy all the way up to radical mastectomy, where they take out the whole breast tissue, axillary tissue, the whole shenanigan. Moving on. Take care of your breast. Do your breast exams. I know y'all all do. Absolutely. So we're not going to go into violence against women too terribly much. We talk about domestic violence or violence against patients a couple times. We talk about it here with domestic violence with women. We'll talk about child abuse as well when we get into pediatrics. So there's various different types. There's domestic violence, of course, but there's also human trafficking. And people, even though you see it on the news, look out for people that might be trafficked. I don't think people realize what an impact it is in our community. Richmond is one of the top trafficking areas on the East Coast. Because think of where we're at. We're 2 hours from any direction to get out of the state. You got 95 and 64 that connects right together, two major highways that you can get out of the way really quickly. So it actually is a big problem in Richmond and Henrico kind of lumped together for human trafficking. So in your profession as a nurse, you have to be aware of, basically I go with, if anything seems weird, run with it and at least investigate. We'll talk about that with child abuse as well. Sometimes you just get a feeling. And your job there is to do more assessment. One of the things that you'll see with human trafficking is they seem not to have very close relate. Like they'll say they're family members, but it doesn't really seem that way. The person that's with them seems very controlling. So the biggest thing with this really is making sure this is where your really important assessment skills come in, and documentation. Document the crap out of this if you see something, because that could be very, very important. This is something that's probably going to go to court if it is investigated and found to be legitimate. So making sure that you're aware of behaviors that seem unusual, reporting it, and documenting. Any questions? Nothing. You're correct. So in this case, let's say you have a situation you see, oh, that ain't right. Let your instructor know, let your nurse that you're working with know, absolutely, make them aware. But yes, as students, that's more of one of those, let's observe this. Because depending on what's going on, law enforcement might have to be called, and, you know, it can get a little involved. Alrighty. So that's an overview. So let's talk about a few like menstrual disorders that we can have. And we're not going to talk about a whole lot. You should know your terminology, kind of like I mentioned at pre-semester. If you don't know what the words mean, you can't answer the questions, right? So here's some terminology that would be beneficial for you to know when we are describing menstrual disorders. So one that you see is amenorrhea. What do you think that means? Just breaking the word down. Yeah, you're not having a period for whatever reason it is. And this can be normal or abnormal. If you are an 8-year-old girl who hasn't started getting your period yet, you have primary amenorrhea. You haven't started them yet, but that's totally normal. If you are a 30-year-old female that's pregnant, that's secondary, because the difference in primary and secondary is you've never had a period. Secondary is where you had them and you stopped having them. So secondary amenorrhea because you're pregnant, that's normal, right? That's an expected finding. One of the big things you see as a cause of amenorrhea is anorexia nervosa. A lot of times that's the first physical symptom you see of anorexia is they stop having their periods because of the protein deficiency. So it could be normal, it could be abnormal, it could be related to something menstrual, it could be something outside, like anorexia. Yeah, absolutely. Even stress. Sometimes women will have menstrual changes just from stress. Yep, yep. Athletes like gymnasts. And unfortunately, a lot of, and I don't want to say everybody, because of course it's not everybody, but in a lot of those types of sports, you do see a lot of extreme weight management, even if it's not technically anorexia. and that can contribute to it, especially when they're, working out 5 and 6 hours a day and not eating 5 or 6,000 calories. That can make a big difference. So it can be either no periods. It could be increased, like metromenorrhea or menorrhagia. Metro means time, so it means their timing's off. So either they are getting them too frequently, they just had a period 2 weeks ago and now they're getting another one, or it's lasting too long, like they've had a period that's lasted 10 days. That's a problem. That it has to do with time. Versus menorrhagia has to do with flow. So people that are having extremely high flow levels for whatever reason it be.
So like, going back to the metromenorrhea,
Mhm.
that's like somebody who has a period twice in a month or
Yep.
something? Okay.
Yep, exactly. And sometimes birth control pills will do that. Sometimes stress can do that. You'll see that a lot in teenagers as a normal process, their body getting used to figuring out a cycle.
And what was the second one?
Menorrhagia, that's where it's too much. So you got a really heavy flow for whatever reason. Endometriosis, which we'll talk about in a second, that can cause menorrhagia. Yes, and fibroids. Yep, exactly. And that can cause you to have some really obnoxiously heavy periods. No, it wouldn't be. It'd be overflow. Yep. Think of menorrhagia like hemorrhage. And I mean, women that have menorrhagia, especially depending on the cause, I mean, it can be significant to the point it drops their. Sometimes women have had to get blood. Have you had blood transfusions and stuff? Yeah. It can really cause a significant blood loss. Absolutely. And actually, that's something we'll talk about with endometriosis. That's the number one cause of elective hysterectomies is endometriosis. Not because endometriosis in and of itself is not going to hurt you, so to speak, but it causes so much pain and sometimes such heavy bleeding. It's more for quality of life kind of thing. But absolutely. And in this case, yes, it absolutely could hurt you if you're having heavy bleeding with it. Yep. They'll do a hysterectomy for that. So as far as psychiatric, we're only going to talk about one thing related to menstrual. Most of you have heard of PMS, I'm sure, premenstrual syndrome. It's very common. It's not considered a psychiatric disorder, where women typically have mood changes and sleep changes and appetite changes and various different things leading up to their period. But there is an extreme form called PMDD, or premenstrual dysphoric disorder. It actually falls as a psychiatric disorder in the psychiatric diagnostic manual. The difference in PMDD and PMS is you're looking at those symptoms, you're probably like, well, how is that different from PMS? They're basically the same. The symptoms are very similar, but with PMDD, it's to the extreme that it's causing them to have decreased quality of life. I mean, extreme mood changes where they can't get out of bed for a few days. And it's like PMS, but on the more extreme form where they really need some kind of treatment. So typically with PMDD, it starts about a week before their period's expected, and about the time their period starts, it goes away. And it's kind of thought that maybe that progesterone has a influence in that. So there's various different treatments for this. As far as dietary treatments have been shown to help. High carbohydrates. If you need an excuse to, eat a lot of carbs right before your period, there you go. Low caffeine, because caffeine's a stimulant. But the increased carbohydrate is dietary. Sometimes they need medications. Your antidepressants are your SSRIs. We won't go into the specific drugs, but like your SSRIs, your Prozac is actually approved by the FDA for this purpose. And they'll take it two different ways. They'll take it either all month, or For some women, it benefits, which I'm not sure how this works because with SSRIs, usually you got to take them 4 to 6 weeks before they become effective. But some women can just take it for 2 weeks each month leading up to their period, and it helps decrease the symptoms. I'm guessing it's a different dose, but it is actually FDA approved to use that treatment modality. Yes, ma'am.
I saw on Law and Order before that a woman got away with murdering her husband. They say that she had PMDD. Like, is it that severe that
It can be. And that's the thing. When you're talking about mental illness, see, I'm from the standpoint where if you go to an ER and you beat up a nurse and you try to say, well, I had a mental illness, I don't care. You should still go to jail. But mental illness is a big arguing point for people when they commit crimes. So absolutely, if they can prove that you had a mental illness that impaired your judgment to the point that you committed a crime, it could be considered a valid argument for killing your husband. I know, right? Yeah, and we'll actually talk about when we get to postpartum, we're going to talk about postpartum psychosis, where the women, I'm sure you've heard about it. I remember one, gosh, what was it, 10 or 15 years ago? It was in North Carolina. The woman had 3 or 4 of her kids in a station wagon, drove it into a river or lake, and drowned them all. Postpartum psychosis. So that is also another valid mental health disorder that you see where women become homicidal postpartum, and they're actually in a psychotic frame of mind. It's scary. Mental health is, I don't want to work in mental health, but I find mental health interesting as far as the disorders. And really, you work in mental health everywhere. There's nowhere you can work, you're not going to see it. So endometriosis, I mentioned. So let's talk about endometriosis. Most people have heard this term or have heard of it, but may not know what it actually is. So with endometriosis, you know you have your uterine lining, right? And it's supposed to stay inside your uterus. But in women who have endometriosis, these little pocket pieces of endometrial tissue get outside of the uterus. So they may implant on the outside of the intestines, along the perineal wall, wherever it be. Which, I mean, doesn't seem like it could be that bad, except this tissue, because it's endometrial tissue, is programmed to respond to hormones. Just like when the tissue inside your uterus, when you have your period, you have contractions of the tissue, so you have cramping, you have shedding of the tissue. This tissue does the same. So women who have endometriosis, it might start out as they're having more diffuse abdominal pain when they have their periods instead of being localized right over the uterus. And then it can progress as it gets worse to where they're having just pain all the time. Very painful, greatly decreases their quality of life. They can have increased bleeding because of it. Painful sex is part of it as well. And like I mentioned, this is the most common cause of elective hysterectomies that you see. Yes, ma'am.
I know a girl, she had this, I believe, and she got on birth control.
Yes.
So what is it about that?
Good question. So when we are talking about taking birth control, just like if you weren't taken for this and you were taken, and it's specifically oral contraceptives or like the injectable, the progesterone, or even IUD, so estrogen or progesterone, it decreases the shedding of that lining. So just like if you were on oral contraceptives, your uterine lining is not going to build up as much. So that's why most people, when they've been on contraceptives for a while, their periods become a lot lighter because your body is basically being programmed that it's already pregnant in its brain, I guess you would say. So you don't build up that lining. So it kind of does the same thing with that tissue. It causes it not to build up as much and expand as much. So it can decrease the symptoms. And usually that's the first line of treatment. Actually, what they use more commonly than the oral contraceptives is usually the medroxyprogesterone, the injection. And that's typically a good treatment for that to help decrease that building. Now, if that doesn't work, they can try ablations where they go in and like cut out the extra tissue. But a lot of women, it ends up being where they have to get a hysterectomy because if you don't have a uterus, you don't have uterine tissue going where it's not supposed to.
So dysmenorrhea, can that happen during
intercourse?
Yep, absolutely. And that's actually called dyspareunia. Let me see. I have it written down. Yeah, it sure is. There we go. And that means painful intercourse.
I think I experienced that one time. I had to go to the emergency room. I was just like interested.
Interested. Did you have an ovarian cyst maybe? Because ovarian
They
cysts will do that.
said it was, I had 2 small fibroids.
Okay. Yep, that'll do it.
So it was like I was just like bleeding, but out of nowhere I stopped bleeding because it was about to take everything out of me.
Oh, goodness.
Yeah.
I'm glad you stopped then.
Like if you have a hysterectomy, you put it down.
Not now. You know, I wouldn't be surprised if that's something they do in the future, but just like I wouldn't be surprised if one day we'll be able to do like uterine transplants. Who knows? Yeah. Yeah. Or even artificial wombs, you know, babies that are born prematurely. They do have machines right now that they've been testing that's like an artificial womb basically that mimics inside a woman's body. It doesn't work quite as well as, you know, a natural but they're working on it. So one day we might have it where if you're born, you know, 24 weeks. It is. It's amazing.
So the drug therapy is the birth control.
Yep.
Is there another?
Yep. Drug therapy is going to be birth control.
So if you have endometriosis and you don't do the elective hysterectomy, are you able to still get pregnant?
Yeah. Sometimes now usually women who have endometriosis, it's very hard for them to get pregnant, and oftentimes they may be told there's no chance you're going to get pregnant, but yeah, and they do often have imbalances with it as well. Yep. Usually it does extremely diminish your ability. It's uncommon, like you said, using fertility treatments. It's pretty uncommon to have a natural pregnancy where there's not some kind of assistance. Yeah, exactly. Exactly. As that tissue builds up, it'll kind of force the body to miscarry. Not with that one. No, that's with the oral contraceptives. It's just where that tissue builds up, it causes increased cramping and things like that. And pain, yeah, those are the big symptoms. Pain, painful intercourse, the dysphoria, and then sometimes they'll have increased bleeding. It's not as common to have increased bleeding with that as it is with fibroids, but it does happen. Yes, ma'am.
Since the tissue is growing in like abnormal places, could it cause like infection or?
No, not usually, because it's still in a sterile environment, so it's going to grow outside of the uterus, like in the perineum, I guess you would say. All right, I'm going to let y'all take a break before we go into gynecological infections.
But what would a normal picture of, I guess, an endometrium, like all the tissues? What would a normal, like how does a normal look? Does that make sense?
Like a real picture?
Yeah, like this is how it looks. Well, this is abnormal,
Right.
So how would it normally look? Just in that line?
Yeah. So this part looks okay. So this is where your uterus is. I know the coloring is a little bit hard. So all these little blue spots that you see are just showing where the tissue might attach. So the uterus here, that's still what you would expect it to look like. Just you take off the blue spots. Right. Yep. You got it. All right, y'all come back at 6:35. Let's talk about gynecological infections. And the reason I say gynecological infections as opposed to STIs is there's a couple we'll talk about that you can get that are not sexually transmitted, like yeast infections. That's probably the one that most people think of when they think of gynecological infections. Lots of women get them. It's pretty common, but they are not considered an STI. So we'll talk about which ones are. So when we're talking about our role, our big thing is educating people on the risk factors, how to prevent them, things like that, as well as identifying risk factors, kind of figuring out what their best type of birth control might be. For instance, if you have somebody who has 4 sex partners, oral contraceptives might not be the best thing because they need some kind of barrier, right? So trying to figure out what those practices are. So I know there are several, actually, I skipped one. Yeah, I was saying, where'd my other one go? So when we're talking about ones that are non-sexually transmitted, just like when you talk about urinary tract infections, you're talking about normal flora and pH and things like that. Those kind of factors can also increase the risk of vaginal infections, whether it be yeast infections, what we often call yeast infections is also known as candida, or even bacterial vaginosis. A lot of times people think bacterial vaginosis is sexually transmitted, and the bacteria can be. But it's also something that women very commonly get for factors, the same thing that increases their risk of UTI. So normal flora and pH changes, the same stuff you've talked about before. So antibiotic use, there's plenty of women we see that will come into the ER. We give them antibiotics and they say, you might as well just give me a prescription for diflucan before I leave because I'm going to get a yeast infection when I take these antibiotics. Some women are just more prone because of antibiotics. We don't recommend douching, which is where I don't think anybody really uses it, but it was a big thing in the 80s, I think it was, 70s, where you put a cleansing solution up into your vagina with the thought of people would actually use it for birth control even. They figured if you wash out the sperm, then you're good, except it just pushes it up even further and makes the problem worse. But, you know. I don't think people really do that as much as they used to, but it does change the pH. Any kind of soap does. So just like they say you shouldn't wash inside your vagina with soap because soap is very alkaline and it makes it a nice, comfortable environment for bacteria and yeast to grow. So anything that increases your pH or increases or decreases your good bacteria, increases bad bacteria, increases the risk of those infections. So I know there's a bunch listed on here, and that's where that chart might come in handy. On week 1, if you haven't seen it, I put a chart where you can organize all your STIs and contraceptives if you wish. I find it helpful to put things in a chart format instead of, paragraphs. But we're going to go through and talk about these. So on page 266 to 268 in your big textbook, there is a wonderful chart in there. It is detailed with, I think it has pictures, if I remember right, that chart. 266 to 268. And that's in your bigger textbook. And it is detailed. It's a great chart. Yeah, some of them have pictures. I was thinking some of them had pictures. It lays it out in nice treatments and symptoms, and it's a great reference. So let's talk about these. So let's talk about our fungal first, just because we're going to do the non-sexually transmitted one. So most people call this a yeast infection. We in medicine call it a candida or candidiasis. Again, very common. Some women are more susceptible to them than others. Typical symptoms, usually what most people think of when they think of yeast infections is itching, bad itching, intense itching. They'll have like a white cottage cheese like discharge, and I apologize because I'm going to be using a lot of food references. So if you eat cottage cheese, I apologize, but it's like a cottage cheese white discharge. Lots and lots of itching. So there's a couple treatments that we can use. A lot of women will go to over-the-counter. So over-the-counter is going to be a vaginal suppository or a vaginally inserted cream. Monistat is the brand name. Miconazole is your generic name of that, but we use generics. But if you go to a doctor, you can get a one-time pill that we call diflucan. Do y'all know the other name for it? Very good, fluconazole. So fluconazole, it's a one-time pill. A lot of times with women though that are susceptible, we'll give them 2 prescriptions. We'll tell them take one now, and then in a week, if you're still having symptoms or if they come back, take the second pill. But it's typically just a one-time pill dose, and that will take care of it as well. So pretty easy to treat. Some women battle this as a very frequent thing though. The other non-sexually transmitted, did you have a question? I'm sorry.
I think these things like pearls.
Uh-huh.
Yeah.
They're basically like a suppository. So it's like the cream that's, held in a dissolvable ball, I guess you would say. Yeah, it's fine. Oh, I don't know about that one. I thought you were talking because I know the monostat will come in. They look like,
They're like pearls. Yeah, they have like herbal.
Oh, yeah, I don't know about that one. Yeah, probably not the best idea. It probably disrupts your flora and all this stuff. Yeah. Oh, nope. No. Mm-mm. You're better off just to not put anything in there. Lord. Yeah, if it's herbals, I don't know. I don't know about that one. So the other non-sexually transmitted one, we'll go up to the bacteria and start there, is bacterial vaginosis. It's another one that's fairly common. A lot of women get it, or not, I shouldn't say a lot of women. A lot of women, there are several women that will get it a lot, I guess you would say. And it's kind of the same circumstance, either through antibiotics or sometimes even having their periods, because when you have your period, the menstrual flow changes your pH, and can make you more susceptible. So various reasons. Symptoms of this is commonly like a musky, fishy odor to vaginal discharge, and it'll be like a whitish or grayish color. May have itching, but not necessarily. It's not like candida where you're going to itch. It's a given. Some women have itching with this, some not. Treatment for this is Flagyl, also known as metronidazole, which it's very important to teach patients not to do what on Flagyl? Very good. Y'all, they always beat that one in your head. Y'all always know that one. We don't want them drinking alcohol for at least 24 hours before and after taking the medication, because it will make them vomit from their toes. I've never personally tried it. I've been to. Yes, it will make you very ill. And then that's that. There's not any follow-up testing. You don't have to go back and get retested or anything like that. And it will go away. Sometimes women that are susceptible to it, Flagyl might just work, but then it's going to come right back. So things like probiotics are really good for preventative, anything you can boost your normal flora. So then let's talk about the ones that are sexually transmitted. So the most common ones you probably see are chlamydia and gonorrhea. Oftentimes we will test for these concurrently when they have symptoms, and we often treat for both. Like if you come into the ER and you have symptoms or even just a potential exposure, we do test for it, and it takes about 2 to 3 days to come back. But while you're in the ER, we're just going to go ahead and treat you for both of them, because the likelihood that in 3 days when we call you with that positive result and you're going to come back and get that treatment is not very high. So we go ahead and treat then. That way, if you're positive, you're done. And when we call you and say, yep, you were positive, but guess what? You've been treated, then we can move on. And if it's negative, it's not treatments that are severely hostile to the body, like some medications. So Chlamydia and gonorrhea, especially chlamydia, the most common symptom, like I mentioned at pre-semester, is no symptoms at all. Chlamydia is very commonly caught like when women get their annual physicals and things like that, when they do the pap smear, they test for that, and they may find it then, but no symptoms whatsoever. With gonorrhea, they may have some burning with urination. Men are more likely to have symptoms than women, burning with urination or penile discharge, that kind of stuff, but most commonly no symptoms.
So you said the chlamydia, that's, no symptoms, how long will it be in your system? If there's-
Could be years. And that's where we're actually, on the next slide, we're going to talk about pelvic inflammatory disease. What can happen when you have these infections and you don't know about it and they progress to permanent damage? Yeah, absolutely. Yep, it can make you sterile. Yep, it sure can.
A gynecological disease you consider like
Herpes
herpes?
is a virus. So we're actually going to talk about viruses, but yes, it would go under the STIs. So with chlamydia, we give a one-time dose of azithromycin, like Zithromax that you take a Z-Pack. We give a one-time dose of azithromycin, not erythromycin, but azithromycin. So for chlamydia, we give the one-time dose of azithromycin. And then if they have gonorrhea, they get azithromycin plus ceftriaxone. Oops, I spelled that wrong. Yeah. And they still get penicillin for syphilis. Good old shot of penicillin in the earth. And it hurts too. If you've ever seen injectable penicillin, it looks like white pudding. It's thick. It's painful. Yeah, a PenVK specifically. A specific type of injectable. I should have specified. But this is what we do. So if you come in and you say, hey, I think I might have been exposed, but you don't know to what or whatnot, we just give you both of them.
So is crabs a real thing?
Yeah, absolutely. It is pubic lice. So you have head lice, you have body lice, and you have pubic lice.
And that's the medical term for crabs?
Now, that's a layman term. Pediculosis pubis.
Okay.
You got pediculosis capitis, pediculosis corporis is the body lice, and then pediculosis pubis. Just keep to yourself. Don't touch anybody. So next one, syphilis. So syphilis is another bacterial infection. You don't see it quite as much as you used to. It's a very old infection. People that used to go crazy, like who is it, Van Gogh? That's kind of what caused their mental illness, syphilis. Yeah, exactly. When you get to tertiary syphilis. So we're not really going to focus on the stages. I just want you to focus on the symptoms you have upon initial infection. So on initial infection, you'll get a painless lesion, like a canker lesion, like a canker sore at the point of entry. So oftentimes it'll be like on the labia or on the penis or something like that. So the point of entry of the virus, you'll have just a painless sore. So if it's somewhere where, say, on the underside of the penis or whatnot, and you're not really looking for it, you might miss it. It's going to go away in a couple weeks. And then it sits there. And that's where you get secondary syphilis, which is where like it's in its dormant phase. You don't have symptoms. You're just sitting there spreading the love around. And then you get tertiary, and that's what tertiary syphilis is where you actually start getting organ damage, including brain damage, and they'll have mental illness issues and things like that. So it really can progress to be pretty bad. And once it gets to that, it's irreversible, the damage. But we're only going to focus on primary syphilis as far as the purposes for our class. Yeah.
All these infections, do they just pop up like COVID, or they've been around forever?
Oh, they've been around for a while. People just don't know how to keep it in their pants. I saw a meme on actually I posted on Facebook about it was a condom talking to a mask, and the mask or the condom was saying, so people don't want to wear you either. It was very cute. But it really is true. I mean, protection. So, syphilis. Syphilis is the one we do treat with injectable penicillin. Typically, it only takes one treatment. However, syphilis they always retest for because there is a potential that it doesn't go away. So usually about a month later, they'll retest. And syphilis actually requires a blood draw to test for. And to make sure the infection is gone. So syphilis is the big one that we do always retest for. The others, it's situational dependent. They may or may not retest for chlamydia and gonorrhea. Ideally, it's best if you do, but especially if you're going through an ER, we might tell you to follow up, but doesn't mean that people will. But syphilis is a big one that really should be followed up because it has a higher.
I don't hear about syphilis.
You really don't. When I worked at I worked at Bon Air Juvenile, the juvenile prison over in Chesterfield, and we saw chlamydia and so every kid that comes in, we do a full like comprehensive STI testing and everything on them. We saw several cases of chlamydia and gonorrhea, lots of them. We only had 2 of syphilis. It was very uncommon. Oh, do you? I've heard that as well, that they're seeing more and more cases. Older population. And that's the thing, when y'all go to long-term care facilities, those people are skeevy. They are horn dogs, and there is STIs running rampant in long-term care facilities because think about the time they came from back when they used birth control. They didn't use condoms. They used like birth control pills, and some of them they didn't even have birth control pills. So now that they can't get pregnant because they're past menopause, they're like, woohoo, let's get it on, and not realizing of all the other things that are going around. Oh, absolutely. Absolutely. I know. I know. Those boys. Ugh. So group beta strep, we're not really going to talk about tonight because group beta strep is a bacteria that lives in a lot of women's vaginas, and for the most part, who cares? When you go to give birth, though, is when it can become a problem because if you have GBS or group beta strep in your vagina and you give birth to a baby vaginally, they can get a sepsis from it. So we're going to kind of put off talking about GBS until next week because that's when we'll really focus on it. And then you've got trichomonas. So you'll often hear this called trick for short, the layman term. Trichomonas has similar symptoms to bacterial vaginosis. You have the musky, fishy kind of vaginal discharge, but it's more of like a green or yellow color instead. So other than the color, sometimes they can have similar symptoms with the BV and the trichomonas, but luckily the treatment's the same. What's the treatment? Very good. There you go. Your metronidazole or your flagyl. So flagyl or metronidazole we use for both BV as well as trichomonas. I think I've heard that because the way you test for trichomonas is actually under a microscope. So you have to get a sample and you put the sample on a microscope slide and you actually look at it and you can see they look almost like sperm. They're little flagellates that swim around. In women, it's kind of easier to get a sample because you can get vaginal secretions, but in men, it's harder to get a good sample. So yeah, a lot of times it's harder to see it or test for it.
Can men get, like, you know how women get bacterial vaginosis?
Mm-hmm.
It can be transferred to men, though.
They can transfer the bacteria, but because a lot of our body parts are internal, like the vagina is internal, it's more likely to harbor an infection versus them with it being on the outside. They'll probably just wash the bacteria off and move on. We got all these internal things that warm, dark, and moist environments that breed infection. Lucky us. So like you were talking about with the chlamydia and gonorrhea, well, what if you have it and you don't know about it and it's just sitting there? That's where you can get pelvic inflammatory disease, or PID is what you'll hear about. So PID, any of the bacterial infections can cause this, but chlamydia and gonorrhea are the most common, where the infection actually travels up into the upper reproductive structures like your uterus and your fallopian tubes and your ovaries, and it's a severe infection. So this is not going to be asymptomatic. Women that come into the ER with PID, they can't even stand up straight because they have so much abdominal pain. They can't stand up. They're walking kind of funny. They're in a lot of pain, and they are going to be admitted. If you get diagnosed with PID, they have to be admitted for IV antibiotic therapy. There's no, we're going to send you home on some, azithromycin or whatnot. So it can be pretty severe. You can die from this. You can get sepsis to the point that you could die from this. So it's a pretty significant infection. Like you were talking about as far as permanent complications, it's also greatly increases their risk of becoming sterile or having impaired fertility. And the reason for this is all that inflammation and all that swelling creates scar tissue. So even once the infection is gone, the fallopian tubes are going to have some scar tissue left behind. It may be minimal or it may be severe, and that scar tissue is going to block that fallopian tube to where those eggs can't get out to be fertilized. This also increases not only your risk of being sterile, but your risk of having an ectopic pregnancy. Because if it's only partially occluded, the fallopian tube, the sperm are small enough they can get in, they'll fertilize the egg, but then that fertilized egg can't get back out and it sticks to the fallopian tube and becomes an ectopic pregnancy. So it does increase your risk of permanent complications.
How does multiple orgasms? Oh,
I don't know. I don't know where you're going with that one. It's all right. I was like, I don't know. I love it. I mean, it's not the wrong class to talk about it in. Like, can you have multiple organisms that cause it?
I read that whole thing.
It's okay. It's okay. You could have chlamydia and gonorrhea. That's so funny. I mean, why not? So, going back to PID, once you have pelvic inflammatory disease, your risk of getting it again greatly increases. So women who have had PID are discouraged from having anything inserted in their vagina. So ideally, they should never use tampons again. They definitely should get an IUD, an intrauterine device that's put up in the uterus, because having that foreign body in there increases that risk of introduction of bacteria, increasing their risk of getting another pelvic inflammatory disease.
But this doesn't necessarily mean you had chlamydia or like.
You had some kind of infection. So chlamydia, gonorrhea, or syphilis. It could have been any of them. Or bacterial vaginosis can do it as well. Most women who have bacterial vaginosis, either their symptoms are mild enough, they kind of live with it if they get it a lot, or they take the flagyl and it goes away, or they take probiotics. But in some cases, bacterial vaginosis, it can explode to the point it causes that as well. So it's some kind of bacterial infection. But there's always some kind of infection. I know, right? We need a break. Right? So let's talk about viral infections. So that was our bacterial, our protozoals, and our yeast. So let's talk about viral. So the difference with viral infections, the biggest difference is the ones we just talked about are treatable. Your viral infections are not treatable. Once you get them, you're stuck with them. They are making advancements like hepatitis, for instance. Hepatitis C, there's Harvoni. I don't know if y'all have seen that advertised. It will actually cure hepatitis C, which is great. So we're getting there, but Overall, the general consensus is right now viral infections are permanent. You can decrease the symptoms and make them manageable, but they're always going to be there. So the most common viral infection is HPV or human papillomavirus. Most of you have at least heard of this because of the Gardasil commercials you see on TV. So, which I think it's great that even if people aren't getting the Gardasil, now they know what this is. Because I remember when I was in college, they talked about that genital warts was the #1 STD at VCU, and I'm like, I don't know. But it is actually a very, very common STD. It's one of the most common ones. So HPV, probably about 85 to 90% of people who are or have been sexually active have HPV. So more than likely, every single one of y'all has HPV. The difference is there are literally hundreds of strains of HPV. Most people that have HPV have one that you would never know you have it unless you had some kind of testing. They don't cause complications. They just kind of sit dormant in your body and, who cares? And then you pass it around. The reason we care about HPV is the strains that Gardasil protects us against. So there are some strains that cause problems, like cancer, for example, cervical cancers, anal cancers, head and neck cancers. And then there are some strains that cause genital warts. Those are the ones we care about, and those are the ones we worry about, and those are the ones we vaccinate against. But there are hundreds of strains, and most, if not all of you, probably have one of them. But who cares? Yes, ma'am.
If you go and say, like, you get tested or whatever, for the range of whatever they test for, is this one of them? Is this on, like, so if I were to go, I don't know.
Like general STI testing?
Yeah. Go to the health clinic and say, hey, do you want an STI test? And you say yes. Is this on?
I think it depends on, yeah, I think you have to specify. And I think it's more deep because there are so many strains of it. It's not used because most people that have HPV, you're not going to care. The way we find out if we care or not, like when you get your pap smears, that's one way they can tell if you start having abnormal looking cells. Or genital warts usually are just diagnosed based on appearance. So while we're on that, let's talk about how you would know if you have genital warts. So genital warts look like, they call it cauliflower-like lesions. They might be skin colored or even a little bit whitish colored or reddish colored, and they look like just bumpy, non-painful lesions. So that's how they would diagnose genital warts. With genital warts, for most of the population, they might get an outbreak or something, and then it goes away and they don't ever have to worry about it again. It doesn't mean that HPV is not living in their body anymore. It's just their body basically toned it down to where it's just living there and not causing them problems. But for some people, they have recurrent episodes of genital warts, and they can get quite large to the point that they can completely block the vagina. Yeah, they can get pretty significant. Treatment for this, when you have genital warts to get to that size, is really just treatment of getting rid of the warts. Unfortunately, they're going to come back probably. So they can burn or freeze them off, cryotherapy. I can't even imagine what that feels like, but they can freeze them off. But unfortunately, oftentimes they do come back. So they can be it can be inside or outside. All the way up into the cervix and everything. So they can get pretty significant, but most people, they'll have an outbreak, they go away. That when they do like their annual physical. Yeah. So that's a good question. So if you have them on the outside, like around your labia, when you go to wipe or something, you may be able to feel them on your own, but somebody who say they're inside the vagina or near the cervix, they might not know unless they go to the doctor for their annual physical.
So there's no like burning during urination or nothing with those?
Nothing. Nope. Usually they'll feel it kind of with their hand. You can, because it feels a little harder than your skin, but it's not painful. There's no discharge or anything like that. I know all the things that can be hidden. Now it's like before you have sex with anybody, come on, I need to do a head to toe assessment on you. I know, right? Exactly. We need need a 72-hour waiting period first for you to get tested, and I mean, why not, right? That won't kill the mood at all. All right. So the other thing that you get with HPV is cervical cancer, and that's usually what they advertise. That's what they advertise Gardasil for, and that's the question I would get a lot of times when boys would come into the prison and we give them HPV vaccines, and I don't need this. I don't have a cervix. Well, let's talk about, first of all, how you can transmit HPV and give it to females, but also what most people don't realize is men can get cancer from HPV as well. Head and neck cancers are the most common, like tongue cancer. They can get rectal and anal cancers as well. There are cancers that men can get from HPV too. But cervical cancer is usually what we focus on. And cervical cancer is scary because, like I mentioned, a lot of times you don't have symptoms of cervical cancer. They're very vague. So it's not something you're necessarily going to run to the doctor for. You're tired or something. Relatively new. What was it? 10 years ago? 10 years ago it came out? 15 years ago? Relatively new. Most of you probably haven't had it. My daughter just got it. She turned 11, so yeah. And usually they get it in 2 doses. They'll get it their 11-year-old shots, and then they'll get it usually around 15 or so, 14. Hopefully you hit them up before they become sexually active. And I say hopefully because when I worked at MCV, we did pregnancy tests, anybody 10 and up in the ER. Unfortunately. I know. Every now and then. It was rare, but every now and then. I know, right? And the sad part is at that age, sometimes they've been pressured, they don't even know what's going on, you know. It's scary. Oh yeah, absolutely. And we'll talk about next week, like with pregnancy and stuff like that, things that can contribute to false positives. But then we can do blood testing, ultrasounds, that kind of thing to confirm it. Yeah. So HSV, or herpes simplex virus, most people just call it herpes. There's actually several different types. There's 2 main types that most people focus on. Type 1 is usually your oral herpes. Type 2 is usually your genital herpes. Of course, they can be transmitted to either location. I'll let you use your imagination of how that happens. But they are very similar in appearance, typically. So type 2 is what we'll focus on. Usually they'll have a cluster of like vesicle type lesions. So if you've ever seen chicken pox, because they're in the same family, if you've ever seen chicken pox or shingles, or if you've even seen somebody that has cold sores like herpes on their lip, it looks like a cluster of just fluid filled lesions. Sometimes they'll be kind of crusty on top, often painful when they have the outbreaks. You can't get rid of it. It's permanent. It's not going away. You can treat the outbreaks, like they'll use a cyclovir, for example, an antiviral medication that helps take care of the lesions. There's, what's it called? Abreva, that gel you can get over the counter. You can put on like oral herpes and it'll decrease the symptoms. But it's basically just symptom management. There's no treatment for it. One thing we'll talk about next week with pregnancy, HSV is an absolutely no-no for vaginal births. If you have herpes simplex, you cannot have, or you should not have, a vaginal birth because the baby can actually pick that up as they transfer through the vagina, and it can cause permanent neurological complications and even death.
Is that if you have the virus or if you're having an active outbreak of the virus?
So that's a great question. So if you have an active outbreak, obviously. Most providers don't like you to have a vaginal birth, even if you're dormant, just because the potential is there. It really would depend on the situation, but it's not ideal, but they may let you give a vaginal birth if it's dormant, not active.
So can any of these other things be transferred to a baby during delivery?
Absolutely. So, the biggest one that you would be concerned about, and I mentioned this a little bit last week, chlamydia and gonorrhea. That's the biggest ones we worry about being transmitted to babies during birth. And they will actually get conjunctivitis. They'll get an eye infection from it, which can cause blindness. So it is one of the most common causes of neonatal blindness is chlamydia and gonorrhea. So do y'all remember the drug we give to prevent that? Very good. We give the ophthalmic erythromycin gel in the eyes, and that hopefully prevents anybody from contracting that.
HPV is given to the babies too.
Not typically. If they were having an active infection, which if they're having an active infection, they wouldn't they wouldn't have a vaginal birth. But if it's dormant, usually it's not a worry for that one. Definitely, it's not a risk
So
that they worry about.
the warts that you can give the baby if you have the warts,
If it's active, yeah.
and they can get it like anywhere else on their body.
Well, typically warts are going to be on your like mucous membrane areas, like where you actually have visible lesions. Yeah.
So,
Yeah.
like, I know, like, when I was pregnant, they test you for all this stuff, and like,
Right.
the group B is one of the things. Is herpes one of the things they check you for too? Like, if you're gonna have a vaginal delivery?
Usually they'll ask you. They don't necessarily automatically. Usually, when kind of early in pregnancy, they'll ask you, "Do you want to be tested for, the whole gamut of STIs?" GBS is one they test everybody because usually you're not going to know. But yeah, that's a good question. No, they don't usually test for it unless you ask for it. So hepatitis, again, there's several different types of hepatitis, GH all the way down. But the three big ones we talk about are A, B, and C. So A is the one that's non-STI. How is that spread? Yeah, exactly. Food, fecal. So fecal oral route is the technical name. So food and water. So when you can ingest contaminated food or water, and you ingest the hepatitis virus, then you can get an infection. So hepatitis A is not permanent like B and C. That's another thing that makes it different. Usually it lasts like 4 to 6 weeks where you'll have intense diarrhea and abdominal pain and things like that. But it does subside. Now, there are people that can go into liver failure from it depending on the severity, but typically hepatitis A is going to go away, but it's going to be a horrible couple months for you. Hepatitis B and C are considered permanent, although, like I said, they have a drug on the market now for C that has been shown in studies to cure hepatitis C. But hepatitis B and C are both sexually transmitted or blood transmitted. So dirty needles, for example, are sexual transmission. So with B, there's a vaccine. There's no vaccine for C. But some studies have shown if you get the vaccine for B, it does decrease your risk of contracting it if you're exposed to C. So it gives you a little bit of an immunity boost. All y'all know about the Hep B vaccine because y'all have it. You wouldn't be here if you didn't.
And it's 3 doses.
Yep, 3 doses. You get the initial and then 1 month and then 6 months. 2?
Yeah, they only gave you, they said that they don't do three anymore. I went to the Board of Health and they only gave you two.
What?
And Castle Branch approved it, I only got two.
Interesting. Because babies still get 3. Huh.
And that's what they said, they were like, they're probably gonna make you go back and get a third one, but they never did.
That's what I was thinking. Because I was like, Miss Richardson let you do that? I wonder if they've changed the dose, like if it's a different dose.
I think so, she said some of them still do 3 doses, but they only did 2.
Interesting. I bet it's a different dose.
Like that third dose would be split between the first.
Yeah. Interesting. Yeah, if Castle Branch approved it, it must be real because sometimes they'll deny the stupidest crap. If you don't write 2020 to 2021 on your flu vaccine, even though it's dated, they'll deny it. Whatever. So HIV. We are not going to go into the specifics of HIV because y'all have learned about HIV. We're just really going to talk about how it affects pregnant women and those giving birth. So when we're talking about HIV, there are our retrovirals, the antiretrovirals that we have on the market now. There are plenty of women who can have HIV and give birth to babies that are virus free. It can absolutely be done. Look at Magic Johnson, right? Yeah, I know, right? Right, exactly. But with the drugs we have on the market now, as long as the woman takes the antiretrovirals through her pregnancy and then they'll give the drugs to the baby for the first 6 weeks of life, babies can often be born virus free and never contract it, which is great. So a couple things as far as HIV, women who have HIV are actually recommended to do cesarean births instead of vaginal births. And the reason for this is because of blood exposure. And you're probably thinking, well, wait, a C-section is you're cutting somebody open. There would be more blood exposure, right? Actually, with C-sections, there's decreased risk of blood-to-blood transmission because it's more controlled. They're suctioning, they're cautering, versus when you have a vaginal birth, there's tearing, there's lots of potential exposure for blood. So it's not that the vaginal birth is a problem in and of itself. It's because of that potential cross-contamination of blood. So C-sections are recommended. And breastfeeding is contraindicated. Now, there are no studies that have shown that the HIV virus is transmitted through breast milk in quantities enough that could infect somebody, but it's something that's not required. So just to be on the safe side, they don't recommend breastfeeding if you have HIV.
Do you need, as a woman who's pregnant with HIV, do you need a charge for that medication, or are you automatically given it?
That's a good question. So now, usually you're not automatically given any medications, but I could imagine, because once let's say you're uninsured and you don't qualify for Medicaid or something, when you're pregnant, you qualify for like WIC, and you qualify for CHIP and some of those ones that only cover children. So if you're pregnant, that would probably contribute to that if you're uninsured. Yeah, you get a lot more benefits through Medicaid once you become pregnant, even if you didn't qualify for before, just as an unpregnant woman. Once you get pregnant, because it's considered, they're looking at the welfare of the child, just like WIC. You as a woman that's not pregnant doesn't qualify, but once you're pregnant, you'll get benefits from that as well. Not that I'm condoning anybody getting pregnant just for insurance coverage, but you know. All right, so let's see what you can identify. Ew. All right, so this one up here, what do you think that is? Very good. That is our bacterial vaginosis. Now, luckily for us, there's no smell-o-vision on here, but if there was, it would be it's a vagina. Up close and personal. Yeah. So this is that whitish discharge. It might be like a grayish color as well, sometimes even clear, but it would have like a musky or fishy odor if we were able to smell it. But that is your BV. How about this one right below it? No. Remember the one we talked about? There you go. So that is that trichomonas. So it would smell, again, very similar to that musky, fishy odor, but it's that greenish, yellowish colored discharge. Right? I mean, essentially it is. Just not out of your nose. So what about this one? Most women know what this one is. Yeah, no, not word. Yes, very good. So that one is your yeast infection, your candida or candidiasis. That's that chunky white cottage cheese-like discharge. This is the clitoris right here. It looks like, so it's right above in the labia area.
It looks like a lot of noise going on. Is it like swell?
Yeah, it'll cause like what am I trying to say? Tissue irritation. Like if this is all red and irritated looking too. So yeah, it'll cause tissue irritation. So this one, it is oral. So this is, I'm glad y'all picked that up. So these are your tonsils that are hugely inflamed. This is gonorrhea. So again, I'll let you use your imagination of how these happen, but STIs can occur in other places of the body besides genitals. So this is where they had other forms of sexual intercourse that resulted in oral gonorrhea. Yeah, fun. So let's talk about the viral ones. What do y'all think this is?
Herpes? No.
Nope, not herpes.
Oh,
Yeah, HPV, very good. Your genital warts. So they look kind of like lumpy, skin colored type lesions. They wouldn't be painful. What about this? Yes, see that little lesion right there? That one single lesion makes you think syphilis. And usually this would be painless as well.
But would you have like a lesion if they had herpes too? Or no?
Yeah, what do you think this is? Yes. Now, this is actually, because I couldn't find an actual picture of genital warts, but this is shingles. If you look at this, is actually shingle, but it looks very similar as far as the clusters of that vesicular type lesions. I guess people don't post their genital warts on Google too much, but I couldn't find. But it's very similar as far as the appearance. I'm guessing it's a. I can't figure it out. I'm thinking it's an arm, maybe. I don't know. I don't know. And then this. What do you think this is signifying? Hepatitis. That's your jaundice. Very good. Well, jaundice is a symptom of hepatitis. So that yellowing of the skin is called jaundice. So we'll talk about jaundice as well when we get to babies. They can get neonatal jaundice for various reasons, but jaundice is just a symptom. Hepatitis in this case would be what was causing that symptom. Very good. STI experts. Yes, ma'am.
So for the herpes, you said that it can go dormant, right?
Yes.
So how long between outbreaks? Like how?
It depends. It really is unpredictable. There are factors that can cause it to outbreak. Like you see people, for example, when they're stressed out, they'll have an outbreak of herpes, whether it be oral or genital. If their immune system gets a little wonky, like for instance, they get sick or something, they get a cold, it can increase their risk. Sometimes they can go years, sometimes they're getting it a lot. So it really is one of those. Exactly.
So like a person who, like you said, they can go years without it. They still recommend them to have a C-section versus like oral birth, even though it's like dormant for so long.
And it is really dependent on, that might be a case where they'll be like, we'll take the risk as long as you, mom, understand the risk that this could happen. But that's one of those, it would definitely be a individual provider preference, I guess you would say. Some providers are like, no, I'm not taking that chance. Some are like, whatever, let's see what happens. Yeah. Yeah, it never goes away. So they will always have the virus and always have the potential to pass it on. Yeah, even when it's dormant. Now, the risk, of course, is greater if you have an active infection, but there's always that risk. I would think so. I've heard people say, at least with oral, I guess nobody really admits to you they have genital, but people that have oral herpes, they've told me it's pretty painful. Usually people that have had, they'll tell me they sense one coming on because their lip or what will feel tingly, and then the lesions will pop up and they're painful once they pop up.
I used to work at a OBGYN and people used to come in and say it burns, like when you urinate.
Oh, I can imagine. Ouch. I can imagine. So for infertility and contraception, instead of me droning on, Let's play a game and see what y'all know. Thought I pulled it up. Now, normally when I do this, I play bingo where I give y'all bingo cards and you can mark them off, but you know, COVID. So we're going to do an electronic format. It's not quite as fun, but gets the point across. Let's see what y'all know. Oh, and y'all are, well, again, usually I give y'all a sheet that y'all can write that, but y'all are welcome to write these down as we go through. Not that you can now see your papers, but. All right, so I am going to give y'all a clue, and you're going to find the answer. So most people know number one. This is the only method that is 100% effective for birth control. Abstinence, very good. So abstinence is the only one that's 100% completely effective. We have lots of methods that are 99%, 98%, very, very close. But the only way you can absolutely say without a doubt you are not going to get pregnant is to not have sex. So abstinence is gone. So of course that answer could work for this as well, but it's gone, so it won't. What is a method that will prevent STIs as well as pregnancy? Very good. So condoms, whether it be male or female condoms, although most people use male condoms, because this is a barrier method that prevents skin-to-skin contact, it is the method that is effective for STIs as well as pregnancy. Most people don't realize, or a lot of people don't always realize that if they're taking, say, oral contraceptives, they might not get pregnant, but they can still get STIs. So that's where part of our knowledge as nurses and our education comes in to teach people, for instance, if they're on oral contraceptives and they're not in a monogamous relationship, then they need to use a method to prevent STIs as well. So the other ones are not, even our barrier methods like diaphragms and stuff, because they're internal, they're not going to prevent STIs because you still have skin-to-skin contact. So what oral hormonal contraceptive is safe for breastfeeding moms? Specifically oral. There's a few up there, but when we're talking about oral, there's two types of oral medications up there, and we'll talk about the difference in the categories. So which one can breastfeeding moms take? It's the progestin. Very good. So the progestin oral contraceptives. So there's obviously tons of oral contraceptives on the market, but they all kind of fall into two broad categories. You have your dual contraceptives, your full dose contraceptives, basically, that have estrogen and progesterone. Those are the ones we usually think of that have a lot of side effects. That they warn people, for example, if you're over 35 and smoke, you shouldn't take, increased risk of blood clots, etc. The other category is progesterone only, or progestin. So this is the group that they are going to recommend to breastfeeding moms. This has a lower risk of blood clots. The reason breastfeeding moms should only take progesterone oral contraceptives is because estrogen decreases milk production. So if they are taking estrogen-based oral contraceptives, it can greatly affect their milk production. So progesterone only. And it doesn't have to be oral contraceptives. IUDs, for example, are progesterone only, so they can use IUDs. The medroxyprogesterone, which is the injectable form, Depo-Provera is what most people call it. You've probably heard it called. That is progesterone only, so they can use that. But as far as oral method, it should be just the progesterone. All right. Can you tell me how long sperm survive in the vagina? Very good. 3 to 5 days. So sperm live a long time. So this is where natural family planning can become a problem. Natural family planning is where you use methods to determine when you're ovulating. For example, they will use calendars to figure it out. They'll check their temperature. and various different things. So if you're using the calendar and you know that you ovulate, say, on the 15th of the month, and you have sex on the 10th, well, you may be okay or you may not, because those sperm may still be partying it up in your vagina when that egg comes down and get pregnant. So 3 to 5 days, that's a long time. They need to just die. So this hormonal contraceptive is most likely to cause weight gain. Very good. Medroxyprogesterone. And most people know that one, even if they have never taken it, even if they don't have a clue about anything else about Depo-Provera or medroxyprogesterone, they know weight gain. That is the number one side effect. And a lot of times that's the reason people will stop taking it, is it can cause some pretty significant weight gain. Yes, ma'am. Me too. When I was a teenager, that's why I stopped taking it. It does. I gained like 60 pounds in 9 months. It was ridiculous. And some people don't. I've heard of people losing weight on it. Yep. And then you gained it. I've heard of people losing weight. Yep, but it is definitely well associated with weight gain. What permanent method takes approximately 3 months before it becomes effective? It's not effective right away. It is the vasectomy. Very good. This is where you can also get some oops babies, because ideally when you have a vasectomy, you should come back and get a sperm sample taken, usually about 2 to 3 months after the procedure, to make sure you're shooting blanks. However, not everybody does that, or they think, oh, I'm fine. So it usually takes about 3 months or 20 ejaculations to clear the system of sperm before you are considered no longer fertile. Do what? They do reverse them. They always tell you there's a chance it won't work to reverse it, but it's easier to reverse a vasectomy than it is to reverse a tubal ligation. Or it's more likely to be effective to reverse it, I should say. So what method is contraindicated in a patient with a history of pelvic inflammatory disease? Very good. IUD. So we don't want anything that's going to be inserted into the vagina. So an IUD, if y'all haven't seen them, they look kind of like a T, and there's usually strings that hang down. And it can be either plastic or copper. They have the copper one as well, that actually works a little bit longer, works for 10 years. And it has a twofold kind of effect. A part of the effect is it does release progesterone to decrease ovulation, but it also acts almost like as a foreign body to keep that egg from attaching to the uterus. So it has a part that it plays in that as well. Typically, most of your IUDs are left in for 5 years. They have had successful tests in Italy and other countries for 7 years. They're trialing it here. Last time I got mine changed out, they asked if I wanted to be part of the study to extend mine out and leave it in for another 2 years. But then he said, oh, they stopped the study. So I didn't get part of that study, but they are trialing it to extend the life of them. But as of right now, current guidelines are 5 years for most of them, except for the copper one. So what decreases effectiveness of oral contraceptives, and a backup method should be used? Very good. Most women know this one, antibiotics. They tell you if you take an antibiotic, you must use a backup method for the rest of the month when you're on oral contraceptives, because it greatly decreases the effectiveness. Other contraceptives are not affected by antibiotics. If you're taking medroxyprogesterone, for example, you have an IUD, all these other things, they're not going to be affected. It's specifically oral contraceptives. There's some other drug, and I don't want you to necessarily know, there's actually specific antibiotics. Don't worry about the specific antibiotics. There's some other classes of drugs as well. Barbiturates is another one. If they take barbiturates, it decreases effectiveness. And seizure medication. So patients that have seizure disorders can't take oral contraceptives if they're on medication, because it's going to decrease the effectiveness of those meds. Where was I? So what method requires daily self-assessment of physical characteristics? They have to assess themselves to figure out if they're ovulating or not. It is natural family planning or natural planning. So there's many different ways, things that go into natural family planning. Most people don't just use one method, they use several methods together. So there's one that's the calendar method, which really only works if you have regular periods. If you always have 28-day period cycles, then that can work for you. But if you're 28 days one month, 35 days the next, 27 the next, it doesn't work because it has to be based on having regular periods. So there's the calendar method. There's the cervical mucus method. Your cervical mucus actually changes consistency when you're ovulating. It gets more thinner and slicker to allow the sperm to slide on up, basically. And then they'll test it with their fingers and feel the difference. Temperature checks, and that's part of natural family planning. With temperature checks, you have to check your temperature before you get out of bed every morning. So they keep a thermometer on their nightstand before they even step out of bed. They check their temperature. When you're ovulating, your temperature will go up about a half to 1 degree. And the reason it's first thing in the morning is because that's less likely to have other factors that would affect changes in your temperature. So natural family planning is where you're assessing yourself to figure out if you're ovulating. Obviously, it is not one of the most effective methods. It's actually more effective than withdrawal, but still not very effective. The reason natural family planning is good, though, is it works for everybody in the sense of there's no religion that it's against. You know, there are some religions where birth control is not allowed. So you can use this with any religion. Sometimes women don't tolerate types of birth control, whether it's they're allergic to them or they have bad reactions. So they're not going to have reactions to this. So there's various different reasons people choose this. I'm trying to read. So what barrier method is fitted over the cervix, and you have to leave it in place for 6 hours after intercourse? Very good. The diaphragm. So if you, and honestly, I don't know of anybody who's ever actually used one. So what's that? Yeah. So the diaphragm, it looks kind of like a cup. If y'all have seen those menstrual cups that are all the craze right now. So diaphragms, you can't just go to CVS and pick one up. You have to go to your doctor and get fitted for it. You have to get refitted if you gain or lose 20% of your weight. You have to get refitted every, I think it's 5 years. You have to get refitted if you have a baby. So it sounds to me like a pain in the ass, but I mean, people like to use it. So you basically take this cup and you insert it into your vagina to cover the cervix with spermicide. You can insert it up to 2 hours ahead of time, but you have to leave it in for 6 hours minimum afterwards, because if you have sex and then you just take it right back out, all that sperm that's sitting in your vagina is just going to go right on up. So if you've got this blocking the path, it gives enough time for all that sperm to die before you take it out. So yeah, exactly. So a diaphragm by itself isn't going to be very effective because we just talked about, you know, sperm live 3 to 5 days. So if you just take the diaphragm out and there's no spermicide on it, I mean, they're just going to keep moving. But if you have spermicide on it, it's going to allow time for that spermicide to touch the sperm, kill them, and then you take it out. And you can leave it in up to 24 hours. That sounds like a long time, but yeah, it's kind of like it's got like a ring and it kind of, yeah, acts like a cup, so it covers the cervix. I got a picture. Oh, but it's going to cut me off. I'll show y'all a picture. Yeah, no. So what method increases risk of blood clots, especially in smokers? I mentioned this one. There you go. So specifically the ones with estrogen increase your risk of blood clots. So it's recommended if you're over 35 and you're a smoker that you don't use the combined oral contraceptives. because it does increase your risk of blood clots. And we'll talk about the signs and symptoms of side effects in just a second with one of these answers. A lot of your side effects or your danger signs that we're looking for have to do with blood clots. I'm trying to read this in the dark. So what method is considered one of the least reliable methods? It has a 75% pregnancy rate. Withdrawal, also known as coitus interruptus or the pull and pray method. It's not really a method. What's that? Yes. It's not really a method, so to speak. It's more one of those, oh shit, I forgot. But it is not effective. You're actually better off to do things like natural family planning, but because people don't always realize that, you have pre-ejaculation and blah, 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 and you can get pregnant from that. So 25% success rates. I don't like those odds. A common side effect after an IUD is inserted, not as a problem, but just a common side effect. Very good. Cramping. So it's very common after IUDs are inserted, even if you already had one in and they take it out and put another one in, to have cramping. The timing is important, though. Typically, you should not have cramping for more than a couple days. Most women, it goes away within 24 hours. If they continue to have cramping after that couple days, though, that can indicate that it's either perforated, the uterus, or something else is going on. But cramping, very normal, because your body sees this as a foreign object in the uterus, and it's going to try and get rid of it. So uterine cramping is totally normal, as long as it's only within the first couple days. So how long does an unfertilized egg survive after ovulation? The only other time that's left, right? 24 hours. So eggs, once they're released from the ovary, don't last that long. But sperm live a long time. So what should be used within 72 hours of unprotected sex to be effective? Very good. Plan B. So there's three kind of types of Plan B. There is a oral type you get from your doctor. There's an oral type you can actually get behind the counter from the pharmacist. You don't even have to get a prescription to get. And then there's the copper IUD they can put in that'll last 10 years. So they do have to be used within 72 hours. They were very controversial when they first came on the market because people thought they were abortion methods, but they're not. And that's why they have to be used within 72 hours. If you have an egg that implants into the uterus, this is not going to do anything for that. What this does is it prevents that egg from implanting. So if you have an egg that gets fertilized, it'll cause it to be pushed out without being implanted. If it implants, it's not going to abort it. It's not going to forcibly cause that child to be aborted, or a fetus to be aborted. So it does have to be used within 72 hours. And this is, that pull and pray method, and you're double thinking the effectiveness of it. You go to the pharmacy and go for Plan B. So what is considered a permanent method in women? Very good. Tubal ligation. So with tubal ligation, there's two different types. What most people think of tubal ligation is where they cut, tie, and burn the ends of the tubes. And this is effective immediately because you have separated those tubes and there are no eggs coming through that fallopian tube. A newer method that you're seeing more and more is where they actually take it, looks like a coil, and they stick it inside the fallopian tube, and it causes scar tissue to build up, which blocks the fallopian tube. Still very effective, but kind of like the vasectomy, this takes a few months, usually about 2 to 3 months to also be effective because you got to have time for that scar tissue to build up. So it's not effective right away, but it does prevent clipping and burning and tying and things like that.
Okay, so what happens to the eggs then if they're not coming down?
They die. So they'll start down the fallopian tube, they get stuck, and they'll just die. Yeah, they'll get reabsorbed back into the body.
So that coil that they put in, It's not, your body don't try to reject it. Like
It can. So sometimes people will, but usually they put it in there so that it won't migrate, ideally. You know, in ideal situations. Let's see. So what method is inserted into the vagina once a month? The NuvaRing. Very good. I feel like people don't use these like they used to. At one point, they were a big thing. Yeah. NuvaRing seems to be one of those things that people either really love or really don't love. There's no in between. So NuvaRing is a ring. It's about yay big or so, a little bit smaller. You usually get they'll give you like a 3-pack for 3 months. So you leave it in for a month. Well, basically you leave it in for 3 weeks. So you insert the NuvaRing, you leave it in for 3 weeks, you take it out for a week so you have your period, and then after that you put a new one in. They can be very effective. I have no personal experience, but like you say, you love it. Sometimes people love them, sometimes they don't. The most interesting thing I found out a couple semesters ago from somebody is that you keep them in the refrigerator. I don't know why, that just blows my mind. I can't imagine being at a friend's house and going in the fridge and, oh, look, there's your birth control.
For the birth control that you insert, do you feel that for penetration? I don't know. You're not.
I have heard some people, I remember a girl I worked with when I was at MCV. She said whenever they would have sex, she would take it out. In fact, the funny part is she's like, you know, my husband knew when he was getting some that night because he'd see my NuvaRing sitting on the bathroom counter. Right, yeah, you do have a time frame you can leave it out. Yeah, but you can leave it out and then insert it, you know, afterwards. Yeah, I was going to say, I was thinking it was 2 or 3 hours you could leave it out. I know, right? Oh, I just had to laugh when she told me that. But, you know, where is it? Oh, this is one of the aches warning signs for when you take oral contraceptives with blood clots. What do you think might be in the aches acronym? Very good. Headache. So when we're talking, and it's on the recorded lecture and it's on the slide. So with oral contraceptives, there's an acronym called ACHES, ACHES, and they are the symptoms that help us identify potential warnings. So A is abdominal pain. If they have abdominal pain, then they should let their provider know. C is chest pain. Chest pain is never a good thing, so they need to let somebody know if they have chest pain. And then the H we just talked about is headaches. On the E, this is eye problems, and specifically what it's talking about is blurry vision or double vision. If they have blurry vision or double vision, that could mean that they have a blood clot in their head, and they need to get that checked out. And then your S, there's actually 2 things that S can stand for. It could be slurred speech, or it could be severe leg pain, like, you know, DVT. So slurred speech or severe leg pain. So those are symptoms that if they have those, they need to be assessed because that could be some pretty serious complications. Abdominal pain. So what method is inserted subdermally? Very good. Implanon. There's several different brands that are on the market. That's only one brand. There's Norplant. That's another one. One of them was taken off the market. Was it Norplant? And that's another one that either I've heard people love it or they hate it. There's no in between. So Norplant or Implanon, those subdermal ones, if you've never seen it, usually it's on the underside of the arm. It's about the size of a pencil lead, not a whole pencil, but like the mechanical pen. Yeah, exactly. And it's, I don't know, 4 or 5 inches long or so. And they insert it under the skin, and it sits there for either 5 or 10 years, depending on the brand. And it releases hormones slowly that cause you not to get pregnant. Some people love them. Some people hate them. Some people have had them removed because it causes excessive bleeding. Some people, yeah. And I've heard of people that they never stop having their, like, it's just continuous. And then some people say their periods stop on it. So it's very just each individual person. Yeah, or subdermal. So it's right under the skin. And you can feel it. Like if you run your finger across it, you can feel like this little rod under the skin.
Didn't they stop doing that? Like, so like my mom had one when
Yep.
I was like way younger, but she had one that was like thicker, and then it made her lose like a lot of her hair.
Yep.
And then I never heard about it again. Like she had it removed. Never heard about it again. And then within the last few years,
Yep.
it's like they started doing it.
Yeah, it was in the 70s and then into the 80s. It was a big method of birth control, and all of them were taken off the market. Like you say, huge side effects. And then they became a big thing again. I don't know, the last 10 years or so, maybe.
So like hers was like.
Yeah, they were
It
big.
was like a big block.
Oh,
Yeah, it was thick.
interesting.
Not like,
Right.
it was thin, but like it just.
I see what, like wide.
Yeah, wide.
Yeah, they got taken off the market for a good 10 or 15 years. So what method requires a woman to have regular periods to be effective? Yes, the rhythm method. So when we're saying the rhythm method, it's very similar to, some people call it the calendar method. So you're figuring out the rhythm of your body, basically. You're looking at, okay, and the reason with the rhythm method, you have to have regular periods is you don't ovulate 14 days after your period. You ovulate 14 days before your period. So when you ovulate bases when you have your period. So if you have a regular 30-day cycle, for example, you know that day 16 into your period or into your cycle, you ovulate because that's 14 days before. But if you're different every month, you can't count backwards. It's too late by the time you get to that point. So women who use that have to have very regular cycles every month. So what method decreases sperm motility and should be used with a barrier? Spermicide, very good. So spermicides by themselves don't work very well. Barrier methods by themselves don't work very well. But when you put the two together, one slows them down and blocks them, and the other one kills them. So when you put them together, they're a lot more effective. So what method is applied to the skin once a week? Yeah, the Evra patch. So the patch came out around the same time as the NuvaRing-ish, similar timeline. This is another one either people love or hate, although I don't feel like I see people. What's that? What'd you say?
I didn't like it. After a while, I was like walking around and very band-aid.
Right. That's why I wouldn't like it. But it's another one people either love or hate, but I don't feel like people use it anymore. But it is. It's a patch. So most patients you see with patches, they wear a day. This one you wear for a whole week. So you get a pack of 3 patches, and you change it once a week. So you put your patch on, you wear it a week, you take it off, put a new one on, and then after 3 weeks, you leave them off for your period week. But you leave it on for a full week. Sometimes people, depending on where they put it, like I remember I had a student, she kept complaining that week she happened to put it like right on her abdomen, but the way her pants were rubbing, it kept trying to pull it off. And you can put it basically anywhere. Most of them are clear, so you're not necessarily going to see it. But like you say, you get dirt around the edge, and I mean, you shower with it and everything. And they can be, so some problems that were happening when it first came out is people that were larger sized, because it's still got to go through all that adipose tissue. So depending on what your size was, it could decrease the effectiveness. So that's where it became a little bit of a problem. What is not considered a true method, and new moms should be educated on its effectiveness? Breastfeeding. So breastfeeding does have a natural component to it to decrease your risk of getting pregnant. However, it should not be used as a birth control method in and of itself. So when you are breastfeeding, it does decrease ovulation. up to the baby being 6 months of age. It oftentimes women don't have periods when they're breastfeeding. Some do, but that's because they're not ovulating. It's nature's way of preventing pregnancy, but it is not foolproof. And the only way it's really effective is if you are breastfeeding every 2 to 3 hours around the clock consistently. Even if you pump, it doesn't have the same effectiveness like actual baby to nipple breastfeeding. So one night your baby sleeps in for 5 hours. Well, there goes your birth control. So breastfeeding should not be used for birth control in and of itself. Now, if they're doing like natural family planning and they want to incorporate that, then so be it. But it should not be advised as a sole means, depending on how motivated they are not to get pregnant again. If they're motivated not to get pregnant again, it definitely should not be advised. So what is a common cause of decreased fertility? Obesity. Obesity is the number one cause of decreased fertility. That's one of our modifiable risk factors. You see lots of women with no other medical problems that cannot get pregnant when they are obese, and then they lose weight and they become fertile myrtle. So the reason for obesity being a risk factor is adipose tissue is an estrogen contributor. It causes the body to produce more estrogen. So with estrogen, it causes that decreased fertility and causes problems with conceiving babies. So obesity is definitely the number one cause of difficulty with getting pregnant.
So it is reversible, like you lose the weight and you can.
Absolutely. Oftentimes when women are obese, if they lose that weight, in fact, they've been so used to not being able to get pregnant that they're not really being very consistent with their birth control. And then they start losing weight and oops, oh, look, I can't have babies.
So even if you have like health like diabetes and stuff like that, if you to lose the weight and be healthy, your chance increase a lot.
Yeah, absolutely.
Not to sound insensitive.
No, absolutely. Yeah.
They, I guess they get told that they can't have kids, but it's really, you don't want to say that.
I know what you mean.
Yeah.
Yeah, absolutely. And it obviously doesn't work for everybody. Like for instance, if you have PCOS, polycystic ovarian disease, this is different because oftentimes women with PCOS, because of their hormonal influence, are obese or overweight. But in that case, it's not the obesity causing it. It's actually a hormonal imbalance they have. So in that case, losing the weight might not be effective because there's something different causing it. But if it's just that they're overweight or obese, absolutely. So I bet you're going to know the answer to this one. So what method can be inserted into the vagina up to 24 hours before intercourse? The sponge. And I will tell you, I've never heard of anybody using this. I'll show you, now that we're done, I'll show you what it looks like. So that is some serious planning right there, 24 hours ahead of time. But you can leave it in. I know I got a picture on here. There we go. So this one you see right here is the female condom. Again, I don't know of anybody that uses those, but sure. This is not actually a diaphragm. It's something called a cervical cap, but it's very similar to the method that you use. So here's your let me enlarge this picture. Right? That's why I like my IUD. I put it in and 5 years later, I ain't got to worry about it. Dang it. Let me go back this way. So this one in the middle, what's that? Right. That's a lot of planning. Right. So this one, it's similar to how, this is technically a cervical cap, which works very similar to a diaphragm, but this is kind of how it works. It's got the handy dandy little strap for you to pull it back out with. But you would insert that up against the cervix, so it acts like a barrier. And then this is the sponge. You see it's squishy, and it does this, it kind of sits up against the cervix, and I would think so, but I don't know. Right. I know. That's what I'd be worried about. What if you can't reach it and you got to go to the ER to get it removed? Right. All right. Any questions? So there's a little bit more in the PowerPoint I encourage you to listen to. Like there's stuff about infertility. We don't really go into infertility too much because you could literally have an entire class just on infertility causes and treatments. I mean, it's extensive. We really just talk about, like we talked about obesity. The most common drug you use for infertility is called Clomid, or clomiphene is the generic term. And this drug just helps stimulate the ovaries to release an egg. So that's one of that first line types of treatments. If that doesn't work, they'll go into more extensive treatments. But there's so many. That's not really the focus of what we're worried about tonight. So STIs, contraceptives, menstrual disorders, those are the big focus for tonight. Make sure you do go back and listen to those recorded lectures because it does have more information for you. You know, listen to it in the car on your way to school. Do y'all have any questions? So next week, we'll be talking about pregnancy. So we'll talk about normal pregnancy stuff, and we'll also talk about high risk and abnormal pregnancy stuff. We will cover everything and talk about everything in class, but there is a recorded lecture on YouTube just about normal pregnancy stuff. So if you want extra exposure to the information before you come, I encourage you to listen to those. The PowerPoints are, of course, under week 2. If y'all have any questions, please email me and let me know. Otherwise, I am going to let y'all go home. What's that?
Do you turn off your email in the middle of the night?
I do not. So don't be surprised if you ever email me and I'm responding back at 3 o'clock in the morning. You know, night shift never goes away. I used to be a night shift nurse, and there are some, now I've gotten better, but some nights I just wake up at 2 o'clock and I'm like, I can't sleep. I'm going to get up.
I just want to make sure when I'm sitting between 1 and 4 and I send your email, I'm not going to miss it.
Well, no, you won't, because I don't have it set where it'll wake me up. So, but if I respond back, don't be alarmed. But no.
They don't turn off their notifications. So when I send them an email in the middle of the night, it won't come out.
Oh, I did that to Miss Richardson one time. I sent her a message at like 1 o'clock in the morning thinking she'll get it tomorrow. No, she didn't get it tomorrow. She got it then. And I'm like, oh, no. She wasn't. But she's like, oh.
I have never had a normal pregnancy.
Oh, really? You haven't? Even in the beginning?
Even at the beginning, preterm labor, I'm always on bed rest and out of the hospital.
Oh, my goodness. Right. Me too. I enjoy talking about pregnancy. So you'll have lots of stuff to tell us.
Everything you like we're saying, I'm like, yes.
Yeah.
I'm the exception to everything.
Right. Good night.
See you Sunday. Thank you so much.
Oh, you're welcome. I will see y'all next week.